virtually meeting. We're all across the country, all across the world, and we're communicating. And just like you solve any business problem, we communicate with Slack, communicate with email, we do text back and forth, we're doing this. Why can't healthcare be the same way? Because you have a problem if you do have a condition, and your doctor or a series of doctors, they're trying to meet your needs. They're providing solutions for you. Why does it have to be the old school, let's drive across town, let's sit there and wait in the waiting room for 30 minutes, let's fill out the same paperwork every single time? That's old. That's not efficient. Let's just use the technology we have at our disposal and treat it just like something we do every single day. And I definitely think the millennials coming up, they grew up. I say they, I'm at the tail end of that, but we grew up with this technology. I remember before internet, when internet came, Facebook, MySpace, all that stuff. And the generation that's coming up, especially with the residents coming out of med school, they believe in consumer technology. They have taken part in the good user experience. And then you get out into the real world, you still got to fax stuff. And no, they're not gonna deal with that. So,
again, it's an old way of thinking. The first thing that people are going to throw up when you start talking about doing that is HIPAA. Well, screw HIPAA. If the patient says, I'm fine discussing this and with everybody in this group of 6 people, then HIPAA doesn't really matter. I mean, HIPAA's, an old school, old line, insurance-based, government-based issue. And yes, patient data needs to be protected. Absolutely. Privacy needs to be protected. But if the patient's okay with it, and my belief is it's the patient's information, it's not anybody else's, then that really doesn't apply.
Yeah, that shouldn't be a concern. I was kind of recently surveying people on this specific topic of virtual care and being proactive and just chatting and why don't you do it? And every parent I talked to definitely wanted it, to talk about their kid, and they have questions about their kid, especially new parents. They're like, why can't I just go ask a doctor questions? Why do I need to come in for a visit? I just need to show them this rash, take a picture, share it. It's frustration that they can't do that, especially new parents. But then I started asking the doctor side, and there's some real hairy issues there. Besides the payment, which you're right, it's totally decentivizing. There's no way for them to get paid. And I talked to a doctor that I'm friends with, and he can be honest with me, and he's just like, how can I get paid for this? If they could let me bill for 5 minutes, like a lawyer will bill you down to the minute. He's like, if I could bill like a lawyer, I'd be happy to engage online all the time. Like, I'm nothing against it. There's just no way for me to get paid to do it. And that's actually just unfortunate. But the hairier issue is actually a supply and demand issue. So the assumption that there's capacity to chat and do virtual care and do all this assumes capacity, assumes there's a supply side that is willing and has a sustainable economic model to engage in that type of thing, because it's going to be less money, it's going to be cheaper, and that's good, right? But what the doctors I talked to were telling me is that's actually like a false claim. Like, most doctors are like super busy and aren't looking to add 2% more revenue to their equation. They're kind of like, that's not a big needle mover for them. And they're already like so busy in the normal day that they're like, even if I could get paid for this, I'm not sure I'd want to do that. Like, I get why consumers want it. It's like a convenience. It's like a luxury. But we're in high demand. There's not a big supply of us. So you're kind of assuming that that's not a factor. Our time isn't a factor, even if we could get paid. And I think that's kind of can be, especially for like the certain doctors, that's, I think, a big issue, is like to assume that all this engagement is available and they can actually do it, even if you figure out an incentive model, isn't necessarily true.
What a great segue for direct care. Why are they busy? Why are they so stinking busy? It's because they're having to do everything non-patient related, which is eating up at least 50% of their day. Their EMR or ERR, as I've renamed them, the electronic reimbursement record, also has some computerese connotations, ERR. I like it. And so if they had all those issues that they weren't dealing with, all of a sudden the time factor becomes less. Also, you can handle things over the phone a lot faster. You don't get behind. But I mean, I fully agree with what you're saying. That's a infinitesimally small portion of the physicians in the country right now. We're out to change some of that. But you know, the other part that really impacts that is, as more and more physicians become employed, their life is not their own, their time is not their own. They're in the cattle dipping, mode where they see as many patients as they possibly can, and that's why people, go 2 weeks and they need a medication refill. They have to go into the office for the same medication that they've been taking. Why? You're told that you have to come back in to see how your levels are. Well, the reality is, if you don't come in, I can't bill. I mean, it's the whole system is perverted and has been for years, and that's why it's a real challenge to try and change it.
Yeah. It's a good point how these things are connected. Like, they're so tangled up in, I book these people for things that maybe I don't need to. I'm charting things I don't need to. And this creates strain on the supply.
Oh, yeah.
That when
Absolutely.
in fact, these things can kind of just correlate with each other, and you would have time and all that.
Yeah, I mean, you look at the amount of time, John, you mentioned 50%. Let's just keep it simple and say 2 hours a day is wasted on your ERR system. You sitting there, checking boxes, typing in stuff, doing, crossing your T's, dotting your I's. Just at 2 hours a day, we have 900,000 active physicians out there. Do the math. We don't have a shortage of doctors. We just have an inefficient use of our time. If you could free up those 2 hours for every doctor, heck, just free up 2 hours for 10,000 doctors and give them the ability now to almost act like an Uber driver and says, all right, well, now I have 2 hours in my day. I'm going to mash this button. My light's going to come on. And now I'm open for virtual care. If anybody wants to contact me, they can. I can have just a conversation with them. I'll answer emails. And treat it like that. And then slowly you can start freeing up some of this wasted time if you go to more of a direct care model, because of course you just remove the need for these electronic reimbursement machines that you have to deal with. So I think that I've been pointing the finger at the EHRs for a long time. I'm just thinking that they are built for maximum billing execution. Is to figure out how to get all the codes right, how to document everything for basically insurance billing and regulation. And if you remove those and create a software solution that helps the physicians, that augments their abilities and saves them time, that's amazing. I mean, that just kind of flips the whole entire paradigm. Now you have doctors with all this free time on their hands. They can sit down and actually talk to a patient. And now we're just talking about doctors. You go on the nurse side, that's even worse. Nurses, they'll work a full 12-hour shift, and they have all kind of crazy stuff that happens. And then they wait to the end of their shift to document.
The chart.
Yeah, to chart every single thing that happened before. Like, are you really going to remember every single detail? No, nope. A lot of stuff gets missed. It's just a dumb way of doing things.
You just hope it's not critical information that gets missed. And you wonder why nurses have sticky notes or dots or whatever, hands all written over. It's because they're having to try to remember critical information that needs to be charted. It's a scary thing. And I mean, I don't know. It's kind of like, I just saw a news article yesterday. Vanderbilt University Medical Center is getting ready to roll out Epic, and they're already forecasting a 60% drop in their operating revenue. Because of the cost of the rollout. It's going to impact both their gross revenue, because they're actually cutting back on patient visits in order to roll this out, and then the sheer cost. That's a big hit on a big university medical, well, a whole system, not just the university medical center. But so yeah, that's why they're so focused on reimbursement. I mean, it costs you $1 gazillion to put one in.
How much is going to cost an Epic installation?
I know that Infirmary, which is a large private system here, and they didn't do the turnkey. They basically tried to say, well, we've got enough knowledge in-house. We'll take on some of these modular aspects. But they spent $500 million on just a part So I think Vanderbilt's going to be up close to $1 billion.
Yeah.
It's insane.
It's crazy. If you guys followed the like political news in the VA and everything, they were, it was actually a good agenda. They had a very good tech agenda. Lighthouse Project, open up the Fire APIs for the VA, but it was getting a lot of scrutiny because they picked VA as a roll your own system, and so they probably saved a lot of money back in the day. But then they couldn't maintain it. It's out of date, so they had to go commercial, and I think Cerner won the bid.
They picked Cerner, yep.
And they got challenged, of course. But at the end of the day, what Cerner was going to charge the VA $7 billion or something, and there's like another $2 billion of implementation costs in there, like,
and ongoing support.
Yeah, right. So it's like crazy how much these big health systems cost.
So that's part of how health systems bill their charges. We got to recover that cost.
Yeah, we need it to bill, and then we need to keep using it to cover it.
That's right.
So why does it cost so much? I mean, what's like the real cost there in Epic rollout?
Well, I imagine the sunk cost is a good part of it because the technology's already there and all the code. Yes, they have to update it, but I think it's personnel cost, and really a lot of it is an implementation. It's like cockroaches coming into your hospital, all these IT people, and then when they leave, you've still got both in-house and external people, whether they're actually Epic or Cerner employees. Infirmary Health hired about 5 or 6 core team guys that they work for Infirmary, but they're Epic trained. And I mean, that's, you're looking at least at $500,000 a year there just for 5 or 6 people.
Forest General had 40.
Yeah.
I mean, the general EMR model is of course like any big enterprise software, they charge you per module. So they're upselling you all the time. They're traditionally not like a cloud on demand based pricing. It's like per user licenses. So you're paying for licenses for probably half the people that actually use the product day to day, but you've got to have them on for the monthly or weekly report that they use. So they're getting bloated user license fees, not volume based fees. They're upselling every module. And then they know they have they have these guys by the throat or whatever, because it is their means to revenue. So they can charge a lot of money, right? But these are super complex systems, so they're super customizable, and they almost want you to customize it. Like Epic has some part of their system called Sonnet or something. It's like the vanilla Epic. No one in the world has ever implemented it. Like they know, and they want you to have to customize it all, and that's where they make a lot of money.
So I just want to point out that some of the discussion today at HIT Expo was the fact that the only thing that really flows seamlessly, actionably, and demonstrates interoperability with all of these huge rollouts is billing information.
Oh, yeah.
So, one of the frustrations from a patient and care partner perspective is most hospitals with all of these mergers have numerous electronic health record systems. None of them talk to each other.
Right.
There's a whole big discussion about duplicate records and the challenges of patient matching and the challenges of even making one doctor talk to another doctor that maybe even are on the same building, same floor. There's no way to get that information without the patient faxing or handwriting a records request that has to go to a medical records department or be faxed, and then the records either have to be picked up or mailed to the other provider. It's disastrous. And it's not a priority to fix. Everyone says, well, who's going to pay for that? Who's going to pay for that?
If it wasn't for healthcare, we wouldn't have fax machines anymore. Somebody else uses them.
That was part of the discussion today because, while it's not, the comments were that while it's not ideal, it works. And who's going to pay for, implementing there's no metric for an organization to decrease paper or manually filled out forms. So we have all these technologies and we rolled out, but we didn't dot all the I's and cross all the T's. So, you know, it's really what the bottom line is. The bottom line, the patient isn't the customer of the hospital. The insurance company is the customer of the hospital. And that was one of the takeaways from the meeting that I got today.
Well, in the majority of cases, the patient isn't paying. The insurance company's paying.
Yeah.
The patient's paying the insurance company, or their employer is, and the insurance company is, quote, paying the hospital. So
we're not really patient-centered. We're insurance company-centered.
Right. Absolutely.
It goes back to the first conversation of why would you roll out a chat thing or like go online and do virtual care? If you're like an Apple or an Apple store, but think about it, like your brand is the experience. So they put a lot of money into their stores because they care about the consumer experience. They might lose money doing that, but ultimately they make money because they're getting more customers because people recognize it as a brand and experience thing. But healthcare like providers, unfortunately, don't have the concept that they need to market to patients in that way, that I'm going to do this. I might lose money on it, like at first, but it's like a marketing cost. But you know, it's a way I would definitely do it if I thought like it's a differentiating going to get me more patients. But no one has that concept of like actually running a business where you're thinking about like your patient's experience as a differentiator for your practice. So then of course, because they're not in that mindset, they say, well, how am I going to make money doing this? Or isn't it taking away from my time? Versus you're using it to like create who your company is, right? And you want a good experience when you walk into anywhere, any other kind of retail venue. They usually care about what it is, or they care about what their online e-commerce presence is. Nobody has that mindset at all, right? So in interoperability, it's even hairier because FHIR is taking off. FHIR is great. I just implemented a FHIR thing in the Community Care Network of Virginia across the state. There's two big issues when we actually tried to roll it out. Technology worked fine. You could sync all this data. Nobody knew their freaking portal login to even authorize it. So like, you know, when Apple is doing their Apple Health kit that did it, it's great, but it literally falls down at the front door. It's just like, no one, you can't authorize the whole thing. So the system that was built is basically not engageable. And then the second thing was that came out that was unexpected is after you had interoperability, physicians were also in such a mindset of, I don't trust other people's data because I usually get a fax of crunched up notes and stuff. So we started delivering them like shipped structured data from other system. And they're like, can I trust this? Where'd it come from? So then they wanted peripheral data about that, and which isn't part of the specification, unfortunately. So there's other issues as soon as you actually do kind of achieve portability. Like it's still not all like the nut's not cracked on that one.
Yeah, that's a good, that's funny though. Just don't remember password. Big system right there.
You need a federated authentication in healthcare because nobody knows these passwords. It's like, yes.
Facial recognition, thumbprint, just keep it simple.
Yeah.
But that was a good point you made too about the patient experience. These doctors and the hospitals and all these clinics, they're not necessarily incentivized to provide that patient experience because it's not a free market economy. You go to the Apple store and you go to any retail store, they're competing on price, on quality, on the customer's expectation, the way the customer feels. I mean, all of this stuff is prevalent in a free market economy where people do compete. Businesses compete for the customers, and healthcare does not have that. And that's kind of the point of this talk. And what we're doing is to try to implement more of these free market principles that allows people to purchase the services they need and they want. And if they don't want to purchase them, they're not forced to. And they're not forced to purchase from this small little network that can go out anywhere they want to and find value in other places that previously have been undiscoverable, which I'm about to share my screen and kind of talk a little bit more about this. So let me see this. Can anybody see my screen?
Yep.
All right. So this is kind of when I started talking about Metaplex. this is our marketplace for free market healthcare. And you can clearly see you got the healthcare buyers and healthcare sellers. I don't know how doctors feel calling them healthcare sellers, but if you think about what it is, they're providing a solution to somebody that has a need, a healthcare need, such as my knee hurts, my back hurts, I got a headache, whatever that looks like. The healthcare buyers are buying a solution to their need, and the healthcare sellers are providing that. So if you start looking at it in terms of what if this was a free market economy, and you did have these transactions that had the markings of people searching for value, people searching for whatever that value may be. It might be price, it might be quality, it might be location. You can kind of go on down the list of what people deem valuable in their purchases. And with this new token standard, I don't know if anybody is very familiar with the non-fungible tokens, but this is a new token standard coming out in the Ethereum community. It's a 721, ERC 721. And that essentially states that you can have one token that is a digital asset, a unique digital asset that represents something unique. For instance, it could represent a knee surgery, a complete knee replacement. And this token can be bought and sold just like any Ethereum or Bitcoin. And now having these new ways to take these particular services that a doctor might provide, such as we're looking at maybe one specialty care visit or one complete knee surgery. I'm just using that as a go-to example. And now these doctors, say a surgery center might say, all right, I know that I want to do 100 complete knee replacements this year. So I'll go ahead and customize these packages with the anesthesia fee, the facility fee, the post-op, pre-op care, and everything that's involved, and also the actual knee, the joint, and put this into a tokenized health offering. And of course, I can put an expiration date on this where it's good for 365 days, and I can put it up on the marketplace. And the other side, the healthcare buyers, such as a self-funded employer, they can go to this marketplace and say, all right, so I have 1,000 employees. I can kind of predict that I'm going to need maybe 10 knee surgeries this year. So let me go out there and put up an ask and say, I want to purchase 10 knee surgeries. I'm willing to purchase them for $15,000 a piece. And I want to have this quality metric. I want to have a 90-day guarantee. And you can put those terms onto your ask, and then you can have other people bid on this. So you can have the surgeons, the hospital systems, the doctors say, well, I'll do that for $16,000, or I'll do it for $17,000, or I'll do it for $12,000. And then you create these new market dynamics where people can purchase based on whatever quality they're looking for, whatever value they're looking for. Because a lot of times on certain situations, like on 99 Designs, for me, when I'm trying to find some freelance designers, I won't necessarily go with the cheapest one, not even close. Like I'll try to find somebody that's has a higher quality rating that meets my guidelines, and I'll contract with them. Kind of the same concept with this is you open up discoverability. Now I think, Ben, you mentioned that a couple of times, where now you can go almost like on Amazon, and you can say, I'm looking for this type of surgery. And if you're coming from a self-funded employer, you can start piecing out together everything you need. Say if you do have 1,000 employees, you can set aside these surgeries, you can set aside these primary care visits, and you can break these things down into 30-day increments, or it's kind of wide open. You can break it down however you want to. Let's just say you purchase 1,000 primary care visits, you purchase 20 MRIs, kind of going down the list, and you're piecing this together into one plan. And once you get it all bundled together, and this doesn't have to be in network or out of whatever that concept is, it can be anywhere. You can find the best quality that you want to pay for, and you piece this together into one easy payment. So once it's all put together, you pay one time, whether you want to pay just on lump sum or you want to pay a little bit down now and then pay on the execution of these services, or break it into a 12 annual period and 12 months equal payments. Whatever you want to do, it's completely open for customization. And likewise, since this is a token, if you do not need these knee surgeries later on in the year, you can put those back up for sale on the exchanges. So somebody else can purchase this, and the doctor's still happy because he already got his money. He got his time slot filled, so to speak. So this creates new ways of looking at purchasing healthcare, and it introduces free market principles. So I think that more and more physicians will start to say, okay, well, just like LASIK surgery, more physicians started saying, all right, so I can do LASIK surgery for X amount and I'm still making this profit. Let me just keep churning these things out. And you see that the quality of LASIK is getting tremendously better while the price is also dropping. And that's a good example of how free market principles are at work in a little part of healthcare. But if you look at the rest of it, it's just completely skewed and doesn't follow any rational pricing guidelines. So this right here, this concept of having this marketplace that is open and transparent and executes automatically with both parties trusting each other, I think it opens up a completely new world for the next generation of health insurance or paying for healthcare.
So I have a question.
Yeah.
That was a really great overview, because now it just made me wonder. So does buying something in bulk or a procedure or a service warrant a discount? Is there that type of a flexibility in this type of a market?
Oh yeah, that's completely a good question and a good thought, because yes, it's like a Groupon model. You buy 100 of these widgets and you get a 50% discount or something. It might not be that large of a discount, but in this concept, just say we do have this one self-funded employer and I have 1,000 employees, and also I can join forces with 10 other self-funded employers, and let's say we're purchasing 1,000 knee surgeries. That's what we agree. So now you can break this off, like you have a big offering, you have a big price tag of a lot of money that you want to pay somebody, and now you have hospitals competing for your money. Hospitals aren't dealing with insurance anymore. They're competing with a direct payment source straight from the employer, straight from this group, this marketplace. And yeah, there's plenty of surgery centers. For one, in Ohio, Cleveland Clinic. Lowe's did the same thing with these reference-based pricing. Same concept. I think it was back surgeries, or it might have been knee surgeries, but they went straight to Cleveland Clinic and contracted out and said, we need X amount of these knee surgeries, and we want to pay upfront, and we want a discount because we are paying upfront. It's just predictable revenue for these hospitals, and everybody likes predictable, straightforward revenue, and it completely cuts out the insurance. So it cuts out that 30 to 40% of overhead that these hospitals and clinics and doctors are spending just to recoup that money that they need from that service. So it blows my mind that not only us, we pay the insurance to manage these payments. At the same time, on the other side, the doctors have to essentially pay insurance as well, and as far as their overhead software goes, to even accept that payment. Makes no sense to me. But to answer your question, yeah, if you can imagine the 327 million Americans we have all purchasing some type of health care service, think about creating these need networks where you have the healthcare, or just us, that have needs that need to be met, and these solution providers, the doctors and the whole healthcare sellers. And now we create new market dynamics for these needs networks. Now you can break it into those peer-to-peer assurance models that we've been talking about, where you can say, for instance, myself, I can start piecing together a personal health assurance plan because I'm relatively healthy. I might say, well, I do want to subscribe to a primary care doc just for whenever I need this. And I also want to subscribe to a pediatrician for my kids, so I can call them and just text them at whenever I want to with a simple question. I don't have to go in there and drag all my kids to the pediatrician. It can be solved virtually. And likewise, my wife, for the OBGYN, something like that, maybe a subscription to her, virtual care subscription. And kind of go on down the list and start piecing together things that I might potentially purchase in the future based on my health background and what I'm more likely to do. And now that you have all these health service offerings that you want to purchase or that are in your plan now, you can join forces with other people in your needs network to kind of form one large fund or one large purchase. And now you go to the people that are selling these and you contract with them directly. If really you start thinking about it and digging into it, it makes a whole lot of sense to definitely find the value that you never could find before, and also to remove the frustration on both sides. One thing, doctors absolutely hate dealing with insurance, and this is going to free up a lot of their time. this is an example too, by the way, of what these would look like, and these are actual prices.
Okay, Brandon, could I ask a question on that last point? So these self-organizing groups, I think, as you're describing it, it's almost like a bunch of individuals in a community or on the same street or something could form a group and not need to seek out these bundled pre-purchase services through an employer. It'd let you like basically break away from the employer model, if I understood you correctly. But who would the system automatically like be the administrator of that, or do you still need someone to kind of admin and manage the group in some way, or the idea is that you don't need that?
I see two different ways you can go about doing this. You know, with Metaplex, I envision this being a platform that developers can develop on top of. And there's going to be a need for software on the healthcare buyer side and also seller side. Because you got to think about it, physicians are going to have an interface to figure out exactly how to set these templates up of what they want to offer. And the employers, of course, the employer benefits side, there's plenty of pieces of software to go in there and manage specific areas, you know, analytics, figuring out exactly how much they need to spend. But to answer your question, what I envision is kind of like employers just going to their employees and saying, all right, we're going 50-50 on this. I'm going to put money into an HSA, and you put money in an HSA. We're going to split it evenly, and then you go purchase your own healthcare plan. And this is an opportunity. You can go and you can self-organize with everybody in this employer group, or kind of do your own thing. But this is your fund, your personal health account, and you can take it with you wherever you go. If you leave here tomorrow, then you have that. Everything that I put in there, you're good to go. You can take it. And what I'm thinking about with these, now this is got to work through some of this math, but this is kind of the idea, is you have your personal health savings account. So let's just take me, for instance. Let's say I funded it and I have $5,000 in it. And let's say that I have to have a procedure that costs $10,000. Well, I have two options. Either I can just use all that $5,000 I have and just pay the other $5,000 out of pocket, or I can go to the network that I'm part of and ask them to cover that in exchange for my commitment on also contributing back to them if they have a medical bill. So for instance, everybody would contribute just a small fraction of their health savings account to cover these bills. It's kind of like the sharing economy on blockchain. It's just kind of, if you look at the health sharing ministries like MediShare, Liberty Health Share, companies like that, somewhat of the same concept, but this is executed automatically by smart contracts. So being part of this network, you're committing that, yes, if I have a large medical bill, I understand that people are going to pay for my bill, but to be part of this network, I'm also committing to pay for other people as well. I mean, it's not going to completely drain your account. We're talking about small fractions, a few dollars, small percentage points. But this contribution amount could be determined by your health score from Humantive. So for instance, if I have a really high health score, I'm an Olympian athlete or something, and I never go to the doctor, well, that means that more than likely, I probably won't use too much of health services. So I'm not going to have too many people contributing to me. Likewise, if somebody has a very low health score, they're more than likely to use a lot of health care. So they might have to contribute more when it's time for everybody to fractionally contribute. So that's kind of what I'm weighing out. And I've filled up a whole entire whiteboard of this math, and it makes sense, especially having all this automated by smart contracts. So it's like you agree to this as you enter the network, and then it just happens automatically. You don't have to wait for somebody to pay the bill or so forth. It's just there. It happens. Does that answer your question? I think I was kind of going off.
Yeah, no, definitely. I think, it maybe raised two other questions. But, one, I guess I'd worry people are going to be worried that if they feel like they're being judged and their health is being judged, and they're going to question the score, and that's going to impact them, how much they pay. There's some tricky things in there, right, to get right from a user trust and experience perspective and buy in to just participate, if that even is the case.
Yep.
But assuming you can kind of solve that, and if it's transparent and accurate, then maybe it's okay. But I think there's going to be some hairy people that aren't the triathletes are going to be skeptical that they'll get judged or the score wouldn't be right. I guess my other concern or just question would be, how do you simplify like purchasing? Like this kind of, I think the really nice thing about what you're laying out is it breaks down like the whole healthcare system and like kind of lets you pick and choose and just feel like you're purchasing things like you do on an e-commerce site or like, so that's good because it's natural and it's like making you make choices, and that's going to have a bunch of good ripple effects. But it also, people don't always understand what they need, or if they didn't buy something, they're going to come try to buy it last minute when they do know they need it. So not everything's going to be proactive. Like how does some of that play out?
I think by having the base plan, the base requirement is a direct primary care subscription. So that alone, if we just take a step back and say, what if every single American, man, woman, and child, had a primary care subscription? They could go see a doctor whenever they needed to, flat fee. I mean, you're looking at $400 billion a year, and that would cover probably 90% of every single thing that needs to happen. Plus, that would curb the chronic conditions, and that's a perfect world. That'd be great. But having something like that, this direct care subscription, alongside this personalized health assurance model, that would take the place of your major medical. So, for instance, if you didn't purchase that, let's just say you do get in a car wreck and you don't purchase a month-long ICU visit, that would come from the community. Everybody would pitch in and pay because it's part of a commitment. If you agree to pay a percentage of your fund to help others, at the same time, those others are contractually agreeing to pay for you if you get in that $1 million car wreck. So, it's kind of just rolling the dice on humanity and see if people do care about each other in a way. But if you look at just like all in all, how much the healthcare procedures actually cost in a direct primary or a direct pay approach, we've kind of been down this road. It's less than $1 trillion. So if you start breaking that out and just a subscription and just pay all those doctors directly a subscription, and then maybe just kind of go with a maybe on-demand type service where it's not $18,000 for a procedure that only takes 30 minutes and you just pay directly to this physician without having insurance in the way. I mean, I think it's a better model than what we currently have now. The answers, we haven't figured all the answers out yet, but I think having this model that creates a frictionless environment where people can easily purchase and find the information they need when they need it.
So what do you think the MVP of it is? What's the minimal? Is this a directory service that lets any provider that wants to come list their services?
Yep.
And at that point, it's a search and discovery tool where like today let me just play devil's advocate. Google serves as this today. Like I can just search and by my zip code and what I'm looking for, I can find someone and I can buy this service. Like I could say that. In reality, I have to become a patient. If I'm not, I don't know what it's going to cost. They're going to ask me if I have insurance. There's all those like kind of more annoying things than a traditional commerce transaction. But the discovery side of it is, I assume I can go find these people. And I think the difference with just what happens today is the prices would be listed, right? Which you never see like on a doctor's website. What are the prices listed for anything? So I think you're saying price is a first-class citizen in this index.
Yeah. Prices. I mean, this is price transparency. Is I think just having price transparency will enable these free market principles to start playing out.
Okay. And then it's just the total price the provider wants to charge, and it's assuming you're not using insurance, or you're using it's assuming you're in this whole new system, right? So it's not just to get doctors to even expose those might mean they have to actually come up with what is the price, because they might not even have prices, right? They're basically like, I bill this code and I hope I get paid X. Should I make that my price, the average of X? Or, but I mean, so I'm just trying to think like, I'm just thinking very like linearly and sequentially to get the minimal thing to get people to sign up for this. Right? You need a two-sided thing. What does each party need to figure out to even just enroll in like the most simplest version of this? They need to actually establish their prices. That would be one requirement.
Yes. And it would be, we're going to start with self-funded employers and musculoskeletal surgeries. So you're looking at knee surgeries. So I keep using this as an example. Knee surgeries, back surgeries, simple, I say simple, surgeries that are predictable. You know exactly how much it's going to cost, without complications. And there's there's multiple surgery centers, like the Surgery Center of Oklahoma. That's an actual price for a total knee replacement. You go down the street, it's $45,000 at Southern Bone and Joint. But there, it's a direct pay price. And so the Surgery Center of Oklahoma, there's a place on Mississippi Gulf Coast in Biloxi. There's multiple surgery centers that are offering their prices just like you see them right there. That is the price. So that's the MVP. These people already know what their costs are. They know how much profit is already baked into that. So all they have to do is literally just fill out an application or a form to create this tokenized health asset and launch that onto the marketplace where people can purchase it. So, that's the easiest use case that I can see.
So that's I think why a lot of the knee and hip stuff you're mentioning ends up being where bundled payments is focused.
Yep.
Because it's somewhere between pay for outcome and pay for service. But I think like a surgery is still super expensive. If you need one of these surgeries and you're going to show me it costs $15,000, I'm okay. Now let's say you get providers to put this up there. There's no downside for them to, I guess, try it out, right? So they'll say, okay, sure, I'll try this, and I'll list. Who, like, as a person that doesn't need knee surgery yet, or I guess maybe thinks I will, I'm going to go on here. Am I signing up to pay $15,000? Or like, what is as soon as you bring out the prices, one thing I think that's going to happen is there's some stuff that's cheap and it's great, or it's like, oh, okay. But then there's some stuff like, wow, that's super expensive. I'm not going to buy that. I thought that's why I have insurance. Like, you're going to, like, what's the answer to that experience? Like, no one's going to click online, I'm going to outright buy $15K for this thing I don't know if I need, unless maybe I'm missing an angle to it.
Well, with self-funded employers, self-insured employers, they do pay that directly. So if they do have 3 employees that need this knee surgery, for example, now what they tell them to do is just go get the knee surgery in this network. We don't have any really say about what doctor you go to or what quality rating they have, what's the outcome. And they go, and one knee surgery might be $17,000, one might be $29,000, and one might be $14,000. But that patient had an infection, they had to be readmitted, it wasn't very good quality. So now, at a self-funded approach, you can say, all right, well, I can kind of predict that I need these surgeries, so let me find the surgeons with the best outcome. It doesn't necessarily have to be by me. And we can find surgeons that have a really good outcome that do this for $15,000, and I can fly my employees wherever this location is, put them up in a 4-star resort and let them recuperate for a week, and it still comes out cheaper. And that's an example of a couple situations that I've heard about. So
you're saying patients aren't on here, but and primarily someone is responsible for administering the at-risk employer.
Yeah, I'm just
running
talking
their own
about.
pool is going to come on here and make those decisions.
Yeah.
And how is that different? And I'm just politics. I don't know their world today. Are they making that fine-grained decisions today, or traditionally they're outsourcing most of that to a health insurer, right, to run some of the administrative side of it?
Multiple things. Yeah, everything I'm talking about now is for that minimum viable product, going after the self-funded employers and the surgery centers. And yeah, these large self-funded employers, they'll sometimes have a team of HR professionals, people that do this and manage their employees, or sometimes they just bring in a third-party administrator and let them manage these claims and rent out their network. I wish Connor was on here. He could shed a lot more light to this. But that is what good employer benefits consultants do. They come into an employer and they say, let me look at your claims data for the past few years. And you look at this claims data and you're like, you had 7 of these same surgeries and they vary from $10,000 to $50,000 per surgery. You had different outcomes on these. You have these patients that are for some reason paying a whole lot for this brand name drug where you could get the same generic for 90% cheaper. And they start looking at these things and they optimize plans, whether that is just directly contracting with these types of centers, these situations, or bringing in some type of insurance model, or just ways to optimize for these self-funded employers. So that's an active, ongoing thing for these employer benefits consultants, and they do a great job. And that's that book I held up on Dave. That's what he does. He kind of goes in there and comes up with these ways of just doing exactly what we're talking about. Like I've read a lot of his work and it's inspired a lot of these ideas. And you go into an employer, and a lot of times you can save an employer 20 to 50% on their healthcare expenditures by doing simple things like reference-based pricing, direct contracting, and direct primary care. And right now we have, I don't exactly know how many employers self-fund, but I do know that about 155 million Americans get their health benefits from an employer. And about half of those, about 75 million or so, they get their benefits from a self-funded employer, and the other 75 million gets it from just an employer that purchases a healthcare plan.
Yeah, the beauty of a self-funded plan as opposed to a full-service plan is you can make those decisions. Smaller employers typically buy these full-service plans, and they have very little latitude in how their employees, exchange, how that works between the employee and the healthcare providers, whether it's physicians or hospitals or imaging centers. And that's where this whole concept of, in that situation, patients go where they're told to go, pretty much, whatever their plan restricts. So whether it's physically telling them you can only go see this doctor or this hospital, if it's not that, it's the disincentives that are built in to direct them to the provider of choice, quote unquote. Not their choice, but the provider that's going to give them the best financial deal. Again, the employer's, carrying the load. That's what they're going to do. They're going to try to reduce their expense.
We're at the point where employers are the pre-authorization at this point. So if there's something that you need before you can go receive like the knee surgery, or even in some cases go to the ER, you have to clear it with your HR department. Or, like, let's just say you need to go to the ER. They start to ask you, well, why are you seeking this treatment? Because if they can direct you to an urgent care, if they can direct you to a 24-hour minute clinic, they're going to try to do that to mitigate those costs. So I think for employers in particular, just to know that there are more options out there in terms of cost, and perhaps more options to give them through doctors that they could now see. I think this is going to be exceptionally appealing to all parties involved.
Yeah, Connor mentioned to me that this one company he's working with, he brought on a concierge type person or a company, and the employer actually pays their employee, I think, $100 just to call this concierge service before they go have a procedure done. Because what this concierge service is going to do is pull up a price transparency list for what this patient needs, and say, hey, don't go to that location because it's going to cost us 200% more. Go over here and let's save $5,000. And yeah, it's worth it paying that employee $100 to reach out and seek help to find a cheaper price. Because if I'm the employer, I'm putting the bill, I want to save money. And not just save money, I also want to send you to the best person so you can be healthier and you can be back at work helping us build this company.
Well, to take it a step further, geofencing does the same thing automatically, and it automatically will put money on a debit card for the employee. I mean, we're talking big expense for everybody: employees, employers, us as taxpayers. I mean, and just as a sideline, I saw just a blurb a minute ago. All the CMS, things, the rules and regulations they put into play. I just saw where 55,000 doctors are getting a 4% ding on their revenue from CMS for not meeting the MIPS requirements, which is one of the alphabet soup government programs. I mean, it's just, and who knows if they didn't really meet the requirement, they may not have documented correctly, all part and parcel back to this ERR. But these guys are taking a 4% hit on their reimbursement just because it's crazy. Why would you want to do that anymore?
And John, do you think providers are going to have, I mean, they traditionally have some price and they're willing to negotiate lower because of volume, right? Like, that's
like
on their end.
Any other business. But I think it depends on who you ask. If you talk to an employed physician, they don't have a clue. If you talk to an independent doctor, yeah, they have a much better grip on what their pricing would be if they were asked to provide a price list. If you look at all the direct primary care doctors, the majority of them, you go to their websites, and if they don't include, they'll tell you a couple of things. They'll say, included in your $75 individual per month fee are all these services. For the services that are not included, this is our price list. So let's say a knee incision and drainage is $20 over and above your $75 a month should you need that. But they have it down to a science. They know what their cost would be because they're independent and they know what it costs. They have taken enough interest to know what it costs them to provide the service. But I will guarantee you that I think we're above now. 60% of the physicians in the country are employed, and it's growing leaps and bounds.
Mm-hmm.
The reasons are obvious. When you come out of medical school with, hundreds of thousands of dollars in debt, and somebody's going to be willing to give you a paycheck every 2 weeks, that's pretty attractive rather than going through the process of setting up your own practice. But
sure,
the downside is that your life is not your own. And you have some suit in your face, and I used to be one of those suits. You have a suit in your face saying you're not meeting your volume requirements, your quality requirements, you're getting too many patient satisfaction dings. Basically, you're not going to get a bonus this year. Not that I've done that because I don't operate that way, but I'm still used to be viewed as a suit. I was more about getting them their bonus. And, but I'm just, I think you're exactly right. But the sad part is the majority of doctors don't know, nor do they really care as long as they get that paycheck every 2 weeks.
Well, I guess I'm trying to grapple with what this is, this Metaplex concept compared to what happens today. And like the delta is, I'm trying to parse out. And so, for example, Bright Health is a company taking on Oscar. I don't know if you guys have heard of Oscar, but they try to do some unique things on plan design. Ultimately, their medical cost ratio was out of whack, and they had a hard time making money. But Bright Health has come in, and then they're actually trying to do plan design by getting providers to lower their prices, but saying they're going to be exclusive in a region. So and providers are more than happy because traditionally they view a plan as like you have Aetna and Aetna negotiates with them, right? Aetna will say, we're going to give you this for this and this for this. And will they say, well, Aetna, has this big network. And so for all the knee surgeries out there, even just from Aetna, only 20% of your members are going to end up coming to me, right? You don't know where they're going to choose to go. You give them choice. That's what you're advertising to them. Bright Health is kind of flipping it on its head and saying, for knee surgeries, we're only going to support them going to you. So providers are willing to negotiate a lower price, and they can pass that lower price on to the members, but it's basically a restricted, you don't have the choice. You're limiting choice.
Right.
So what I'm wondering here is, are you asking an employer to figure out these complex plan dynamics, or when they purchase 5 knee surgeries, does that imply that they're saying all my employees are just going to go to you? Like when they purchase it, they're purchasing it for one provider, Brendan. So this is basically creating similar to what Bright Health is trying to do, which is you're going to buy stuff and you're going to direct all of a certain type of service to one provider in a region, and you're basically not going to be giving them choice to go anywhere. Or is that am I coupling something that is not necessarily how it would work?
I mean, you can do that, but we also got to look at the price for one, and also the quality outcome of this, because surgeons do have a specific rating of how well they do with their patients and the readmission rate and all that good stuff. So if you're looking at it in just a sense of you want the best possible service for your employees, and if you have a way to discover that value in a marketplace type environment, and you can send your employees to a specific provider. It's like this book I have over here, The Innovator's Prescription. It talks about solution shops, just like a surgery center that just does knee surgery day in, day out. They get really good at doing just knee surgeries. They figure out all the pitfalls, all the obstacles, the things that could go wrong. They have checklists they go down, and they do it cheaper, they do it quicker, and they do it better. And I think it's wise to send all your knee surgeries to this specific place versus this orthopedic center right down the street, just because it's close to you. They might not do a good enough job, but at the same time, we're talking about you can do that. You can purchase 10 different knee surgeries, 2 locally, 3 100 miles away, and the remaining in another state if you wanted to. So it's open for a dynamic purchase.
Those have repercussions on your employees. They don't want to travel out of state, or they want to go to someone else. That's what I'm saying. Like, so plan design gets into these multi-dimensional complexities of what you're offering. Can people even understand this? Is it work one way with one type of service and different for this? I'm trying to grasp. Are we shifting complexity, reducing complexity, or increasing complexity?
Initially, there's going to have to be this hump that we do get over. It's the complex part where, yes, providers are going to have to figure out what exactly I want for this service. What do I want to get paid? And that's why we're looking at surgeries, because they've already figured that out. They've already figured out where their margins are, and they can offer it just as is because they're already doing it. So with the thousands of other doctors and different procedures they have out there, there's going to be that learning curve to set up what this health offering looks like and the terms and conditions they're willing to go with. And once that template is set up, I mean, it's just as simple as duplicating it. Say, I want to offer 100 of these knee surgeries, 100 of these back surgeries. And if you do realize that, there's one term in there that I don't think is best for us, you can change that up and offer it differently. So, on the employer side, this is something the employers have been dealing with since they started offering health benefits, is trying to figure out how to save money doing this. They have departments trying to figure this out. So they're spending money, and if we can automate this processes with maybe more analytics. I mean, hey, you see some companies. Connor keeps showing me some of these data points that these companies are operating blind. They have no clue. They just let their employees go wherever they want to, purchase whatever services, whatever doctors, whatever medications they want. At the end of the year, they pay it all.
The free for all.
Yeah, it doesn't make any sense. But now if you can bring in some analytics and refine exactly what we're spending and make accurate predictions for the next year and direct your employees to the best place for the best price, then yeah, it's a win-win.
Mm-hmm.
So for me, as basically self-employed and not an employee, this is really good. And so we've been a lot talking about the employee-employer, but there's also all the independents, all the consultants that have to buy things themselves and go to, right now, the affordable care. So things are going really bad on that side. What's that?
That's a misnomer, by the way.
Yeah, I mean, exactly. So all, including all the millennials now that are going independent, that segment of the population, I think, is going to find this really, number one, affordable, but also really easy to use. I mean, it's easy for me to go, and for example, I mean, I do a lot of sports. I don't visit the doctor a lot, so why can't I have buy 3 physical therapies at the beginning of the year, and by the end of the year, if I use only 2, can I sell them? The provider is happy. They sold 3. I use 2, I'm happy, and somebody else is going to buy them, to the market. So all this exchange that's going to happen from independent users and buyers is really interesting. So maybe my question to Brandon is, do you think we should go for everybody, or just get the segment of the population that's really need this kind of service?
Yeah, I'm going to say there's 2 points that I really think could be our first approach is the self-funded employers. I think a lot of people are going after them, but then the whole freelancer economy, the 1099 economy. And I was looking for a stat, and I've said this twice today, but I think in 10 years, the gig economy, whatever you want to call that, is going to be equal to the W-2 employees. So 1099 and W-2 are going to be equal in about 10 years, which is huge. And I need to back that up because, like I said, I can't keep saying that if I'm not 100% on that. Is that true, Megan? I know we talked about this.
There's actually a link I believe I put it in the Slack channel, but I believe in the millennials are driving that workforce right now. I believe 47% of millennials freelance, and it's supposed to overtake even work by 2027. So we'll have like 53, I believe it's 53.8 million people who will do some sort of freelancing work, and not maybe necessarily just because they need it. They want it. They want to have that flexibility. They want those other options. They don't want to be dependent on employers anymore, and it gives them more flexibility to grow their skill base. And then if they take it full-time, they can, but they don't want to be beholden just to one option, one employer. It's astounding. That is, of course, if trends continue. If trends continue and we keep climbing, the freelance economy will basically be the economy. They already contribute $1.4 trillion into our economy yearly, just from the work that they contribute.
I think the other side of that is, and Brendan, we've talked about this, is in my area, I live in a resort community. We have an awful lot of small businesses and an awful lot of employees that work for small businesses whose companies cannot afford any kind of health care. They're on their own. So you've got realtors, you've got nursery workers, you've got all, condominium cleaners, you name it. People are working, making a decent wage, but they have no access to reasonably priced health care. So I'm estimating that's somewhere around half of that 53 million today. There's probably 20 million people who are working that have no access outside of Obamacare, which is essentially no access. They're not going to pay that kind of money. They're not going to do it. They can't afford it. And they don't need what Obamacare offers, which is a full service plan. You don't have any choice. You can't just go buy a catastrophic plan in case, your car falls off a cliff. You can't buy those. They're illegal. And so people choose basically to go bare or go to the urgent care when they need something. which is all well and good. But I'll guarantee you there's a large percentage of those folks that want, especially for their families, access to a doctor. And if it has to be over the phone, great. Bobby's got a rash, like you said. Bobby's got a rash. Here's a picture. The doctors are generally smart enough to say, well, that's kind of inconclusive. I'll meet you at the clinic in an hour. It's 3 a.m. or whatever. That's the way direct care works. But I would wager 80% of those calls, 80% of those issues can be handled over the phone, whether it's verbally or pictorially. So that's exactly, and Brendan and I talked about that today, with this gig economy coming forward. Hell, I'm a gig economist. I'm not working for anybody.
It's so true. Think of that possibility.
Oh yeah. Yeah.
The
Just makes
possibility.
sense.
Why is catastrophic illegal? Or I missed that, but that seems like a big issue. If this idea of people picking and choosing small pieces does assume you have some umbrella general thing for all the unexpected stuff, or else you're always going to have that issue. And if the only way to solve that is buy something that covers kind of everything at a high price, it's kind of like a catch-22 unless you can offer the umbrella insurance as just this. So then I can start making more intelligent decisions, right?
Well, I think the genesis for a lot of that is that in putting together the ACA, the pre-existing conditions was a huge deal. Covering, they call them MEBs, minimal essential benefits. Mm-hmm. Unfortunately, they applied it across the board. So, I'm paying, I'm on Medicare, so I'm not a fair case. But before I went on Medicare, today, if I was under the ACA, I would be paying, part of my premium would go to provide GYN services. I don't need them. Okay. It's like women don't need prostate exams. I mean, it just doesn't make sense. But rather than apply it logically, they went across the board. And I know that the insurance lobby had a big part to do with that, because the insurance companies make a lot more money selling the full service than they do selling a catastrophic piece. Because theoretically, and it's the way it was before we got into the ACA, you could actually, and most people did, they paid out of pocket for primary care, and they had that major medical plan, which was perfectly legal umpteen years ago, which cost them maybe $300 or $400 a month, and they paid for everything else out of pocket. But once people got the idea that you could make a shit ton, pardon my French, of money from healthcare, you wouldn't pay $1,000 for an imaging study. You get it for, maybe a couple of $100. Perfect example. I had to have a cardiac calcium score. I went to the local hospital, was on the same CT machine they use for everything else, same tech, maybe a little bit difference in time. You know what my cost was? $112. I had to pay cash, $112 because Medicare didn't cover it. That same CT machine and that same tech and that same amount of time would be 6 to 8 to maybe 10 times more under insurance. And somebody's making money somewhere.
That's interesting. I actually didn't know that history, that the dynamic to start making it illegal or the lobbying came from payers, came from payers because they it wasn't a lucrative offering for them.
It was a gold mine that was waiting to be had. And I guarantee you that AHIP and all the lobbyists that work for the insurance companies, I mean, you go back and look at the rate of increase. I saw a little blurb today from 2007 to 2012. United Healthcare's net profit went up like 276%. So, and maybe those years are wrong, but basically encompassing, maybe it was 2012 to 2017, but whatever. Huge increases. All the insurance companies, everybody else was, an average of maybe 17%,
Sure.
profit growth. I mean, it's absurd.
So I'm just wondering how coupled this is versus it's not undermining this whole thing, is it? That you, assuming you could offer a catastrophic product like anything else on this marketplace, but if it was illegal, or is this marketplace of piecemealing stuff and bringing price transparency, is it dependent on kind of being able to allow people to have a cheap catastrophic plan as a foundation, or can it operate in today's environment without maybe being able to have that?
I think it can operate. I think it would be great to have that. I mean, I would advise people to do direct care, especially for primary care. And if that catastrophic policy was available, something that had, let's say, $1 million cap, and beyond that's reinsurance, and you could get it for individual for $250 a month, I'd advise that in a minute. But and go back to something you said earlier, Ben. If an individual goes out and they say, look, my doctor told me that I'm going to have a knee replacement, and I go out and I see this $15,000 price, yeah, I'm going to kind of close the lid on the laptop and don't know what I'm going to do. But these places are doing financing arrangements. I mean, they're going to be willing to work with you because there are people out there that don't have that. I mean, that's Surgery Center of Oklahoma that Brendan alluded to earlier. That's a large part of their business as individuals. But they also offer that price to companies. So again, it depends on the size of the purchase. But yeah, I think it would be great. And that's one thing I would really advocate for, is bringing back these major medical policies for people that want them. But the insurance companies know if they brought them back, they wouldn't sell any of these large full service plans.
And that's great, because that's an avenue of disruption. But if it's illegal, like if this marketplace lets somebody offer those catastrophic plans, and it would make sense for them, and they could offer, then that's great. But if it's illegal and the whole premise of piecemealing other stuff depends on it, I was just worried that because I wasn't aware they were illegal. I totally get why plans may not want to offer them, because they're going after the more lucrative stuff and trying to game the market and all that. But if they're, I'd never heard that they're illegal.
They're illegal, quote unquote, with very few exceptions. And one of them is very specific. Nobody over 30 can have one. So in other words, and if you're between 26, which is, as a child, 26 years old, boom, you're off your parents' insurance. So there's a 4-year gap that with certain circumstances, you can purchase a catastrophic plan. But how many 27 to 30-year-olds are going to do that? Okay. But what happened was that was the ACA. So it was only illegal, quote unquote, under the ACA. But what happens every time there's a governmental program? Businesses and companies and insurance companies glom onto that. It's everything else that's ever happened under Medicare happens on the private side eventually. And that's really kind of where it came from. You can't buy a catastrophic only plan, an insurance plan today, generally speaking. They're not available. However, there are these association health plans which are starting to, the administration approved those. They're promulgating all the rules and regulations now, but that's a kind of a similar approach to, these catastrophic plans, because you can then make those association health plans. You have much more latitude in how you make those work. So let's say, for instance, the National Realtors Association has, 350,000 realtors. They can go in as a group and negotiate coverage, some of which may indeed be just a catastrophic piece only.
Mm-hmm. It's interesting. They both actually need each other. It's kind of like you need this safety net to want to go and piecemeal and buy other insurance. And the idea of being able to have memberships and pay for primary care and piecemeal it also creates a market for the catastrophic.
Right.
So it's like they both can't exist today, but if you had a platform to enable them, then they both maybe become feasible.
Well, right now people are buying these health sharing plans, which are legal. They're not as traditional as catastrophic insurance plans. And I think depending upon the organization that's selling these plans, some have been taken to task for not providing coverage as, it was alluded that they were going to provide. So they caught a little heat. But as far as an option for somebody to have that, at least a minimal amount of comfort in that they'll be protected if they have a car accident. And obviously, if you have cancer or, cardiovascular bypass or whatever, that might not be sufficient. But some comfort is better than none, and they're very reasonable. And you have to go through a few more gyrations. It's not like you just show the card and they say, oh, fine, no charge, boom, you're covered. It's a little more involved, but it puts the patient with those plans to have a little more skin in the game. But that's for another time.
Sure.
Yeah, everyone, I need to go. I need to get out of here. My wife is constantly messaging me, so I think I need to go. Thanks, everybody, for the good conversations. I think we made some progress tonight.
I do too.
I like working through this. I think we're on something, a good opportunity in terms of something that is completely radical and way out there, but at the same time, it seems very feasible to do, especially with this newer technology. So let's keep the conversation going.
Sounds good, guys. I'm going to go feed my face.
Thank y'all.
Bye.
See you.
Everybody. Thank you.
Thank you. Bye-bye.